Welcome to today's deep dive. Usually a medical diagnosis implies a lot of structural precision. Like if you fracture your tibia, it shows up on an X-ray as this jagged white line.
Right. The pathology is completely visible. It's a mechanical problem with a mechanical solution. The bone is broken, you stabilize it, and the cells just bridge the gap.
Yeah, exactly. But when you step into the landscape of pelvic floor trauma, specifically from childbirth, that structural precision just vanishes completely. The waters are incredibly murky.
They really are. We transition away from objective imaging and move into subjective pain scales, which leaves so many patients navigating a system that, frankly, doesn't fully understand the biomechanics of their injury.
Okay, let's unpack this. Because for today's deep dive, we are synthesizing a really fascinating, highly specific stack of sources for you. We're pulling from clinical case reports in the IMR press, treatment guides from specialized clinics like the Women's Health Clinic, and strict UK regulatory frameworks from the MHRA.
And the specific mission for this session is to look at all of that and answer one cutting-edge question for you. Do intimate exosomes heal vaginal tears and episiotomy scars?
Right. And to answer that, we really have to explore this wild intersection of childbirth trauma, stem cell biology, and, very strict medical laws.
Because regenerative medicine is completely changing how we view women's intimate health. We're moving away from just masking pain with pills to actually rebuilding damaged tissue at the cellular level. But before we can talk about cellular healing, we have to understand the physical reality of the trauma itself.
And the scale of this issue is just staggering. Looking at the sources, over 85% of women experience some form of perineal trauma during a vaginal birth. 85%.
Yeah, it's a hidden epidemic. And we aren't talking about, like, superficial scrapes here. The medical field categorizes these tears into degrees. Understanding the depth of that tissue destruction is vital to understanding why these scars are so debilitating for you or anyone dealing with them.
So break that down for us. What do these degrees actually mean structurally?
Well, a first-degree tear is limited to the superficial layer, right?
Yeah.
Just the vaginal and perineal skin. But a second-degree tear, which is exceedingly common and is actually the standard depth of an episiotomy, that breaches the mucosa and tears directly into the perineal muscles.
The bulbospongiosus and the transverse perineal muscles.
Exactly. And it progresses from there. A third-degree tear extends downward into the external anal sphincter.
Oh, wow.
Yeah, and a fourth degree goes entirely through the sphincter complex into the rectal mucosa. So we are looking at deep, multi-layer musculoskeletal trauma in a highly vascular, nerve-dense region.
And when that tears, or, when it's intentionally cut during an episiotomy, the body's repair mechanism just panics. It's frantic. It doesn't lay down a neat, elastic basket weave of healthy type I collagen.
No, it rushes the site with fibroblasts.
Yeah.
And those just dump dense, rigid, parallel bands of type 3 collagen just to close the wound as fast as possible.
And that rigid type 3 collagen is the defining characteristic of fibrotic scar tissue, right?
Right. It lacks elasticity, it traps nerve endings, and because the pelvic floor is this dynamic hammock of muscle that needs to stretch and contract constantly. I mean, for sitting, walking, urination, intercourse, a rigid band of scar tissue essentially acts as a localized tether.
It's just creating constant mechanical tension on the surrounding healthy tissue, which honestly makes the traditional standard of care outlined in the sources seem almost absurdly disconnected from reality.
It really does. The frontline treatments traditionally offered are NSAIDs, topical numbing foams, cold packs, and herbal sitz baths.
Like chamomile or lavender oil. I mean, standard care sounds like putting a bucket under a leaky roof without ever fixing the hole.
That's a perfect way to look at it. Standard care operates under the assumption that the problem is just acute temporary pain that will fade away.
But painkillers just mask the pain temporarily. They do absolutely nothing to fix the actual structural scarring that causes long-term complications like dyspareunia and painful sex.
What's fascinating here is that the medical field finally realized they needed a regenerative approach, because a sitz bath might increase superficial blood flow, and ibuprofen will temporarily reduce acute inflammation. But neither of those can remodel type 3 collagen back into elastic type I collagen.
If the muscle is bound by fibrotic tissue, numbing it for 4 hours doesn't restore the mechanical function of the pelvic floor at all. You need a biological intervention to trigger the body to break down the fibrosis.
Exactly. Which brings us to the treatment that is currently successfully treating these deep scars in clinics today, PRP, or platelet-rich plasma. We need to look at how PRP works before we can even evaluate exosomes.
Right, because there's a really detailed case study in the IMR press that perfectly illustrates this. It's about a 31-year-old woman suffering from a second-degree deep episiotomy scar on her right vaginal wall.
And for 10 years following her first delivery, she experienced escalating chronic pain.
10 years. 10 years of severe pain during intercourse and sharp discomfort just from sitting or urinating. The mechanical tethering was so bad, she actually elected to have a C-section for her second birth just to avoid aggravating the scar.
Traditional analgesics completely failed her for a decade. But when she went to the clinic, they bypassed pharmaceutical pain management entirely. They used BRP. So they drew 10 milliliters of blood from her saphenous vein.
And then they centrifuge it, right? But not just to separate the plasma.
No, they meticulously isolate the specific layer where the platelets are most dense. They strip away the red blood cells and most of the white blood cells because you don't want an unnecessary inflammatory response if you inject that back into a closed scar. They're isolating the alpha granules inside the platelets.
And those alpha granules are the payload. So in this case study, they injected that concentrated PRP directly into the matrix of her deep scar.
3 times at 3-week intervals. And the results were astounding. The moment those platelets hit the deep tissue, they release a massive influx of growth factors, primarily vascular endothelial growth factor, or VEGF.
Which triggers neoangiogenesis, right? The sprouting of new blood vessels.
Exactly. The PRP forces the body to flush that hypoxic, starved scar tissue with a new blood supply. That allows macrophages to clear out the rigid type 3 collagen and synthesize flexible, healthy tissue.
And the metrics prove it works. They use the Vancouver Scar Scale, which measures scar height, pliability, vascularity, and she showed a 66.67% overall improvement.
The scar physically flattened and the pliability returned, and her pain dropped by 80% on the visual analog scale, from a paralyzing 10 down to a 2.
A decade of chronic pain reversed just by forcing the tissue to vascularize. But here's where it gets really interesting. I have to push back on this.
Actually, go for it.
If PRP is already doing this miraculously well using a patient's own blood, meaning it's highly biocompatible and cheap to harvest, why are we even talking about exosomes for the exact same problem? What makes exosomes the necessary next step?
That is the crucial question. The limitation of PRP lies entirely in its reliance on the patient's own biological state. It leverages the platelets you happen to be producing on the day of your blood draw.
Oh, I see. So if a patient has an underlying autoimmune condition or chronic inflammation,
Or they're just older, their plasma is compromised, the yield of the growth factors is subject to cellular aging.
so if PRP is like harvesting your own local resources and hoping you have enough bricks to rebuild the wall, exosomes are like airdropping highly concentrated, lab-perfected instruction manuals that tell the cells exactly how to rebuild it themselves.
That is a brilliant analogy,
Yeah.
yes. Exosomes bypass the variability of your own biology. They're these tiny extracellular vesicles, just 30 to 150 nanometers in diameter.
So small.
Incredibly small. And unlike PRP, they aren't from your blood. For these clinical applications, they are often derived from pristine, lab-cultured mesenchymal stem cells. They carry a payload of proteins, lipids, and most importantly, messenger RNA and microRNA.
And that cargo is what hijacks the damaged cells, right?
Yes, PRP just bathes the outside of the surrounding cells. But exosomes actually fuse with the target cells. They merge their lipid bilayer with the cell membrane and drop their genetic instructions directly inside.
So they literally force the cell to change its behavior at the DNA level.
If we connect this to the bigger picture, clinics like the Women's Health Clinic currently categorize exosomes as the investigational gold standard for cellular signaling. They're deploying them to combat severe vaginal atrophy and complex autoimmune conditions like Lichen Sclerosus.
Where the immune system aggressively attacks the vulvar skin, causing severe thinning and scarring.
Exactly. Steroids are the standard treatment, but they thin the tissue even more over time. Exosomes drop that mRNA payload in, halt the autoimmune attack, and instruct the mucosal lining to regenerate its own vascular supply.
That is incredible. But wait, this brings up a huge contradiction. If exosomes are the ultimate biological instruction manual, why aren't they immediately replacing PRP for deep episiotomy scars? Why aren't doctors just injecting exosomes into every second-degree tear?
This raises an important question, and the answer is the strict regulatory reality we live in. The MHRA in the UK and the FDA classify exosomes as biological products. Because they are derived from human donor tissue, there are massive ethical concerns and fears about communicable diseases.
So they are heavily regulated.
Very heavily regulated. Because we lack long-term data on what happens when you inject foreign mRNA deep into a patient's muscle, it is currently illegal to inject exosomes in the UK.
Wait, illegal? Entirely.
Yes, they're strictly limited to topical applications or microneedling, which just creates surface-level micro-injuries for absorption.
Wait, but an episiotomy scar goes deep into the muscle like that second-degree tear we just talked about. If doctors can only apply exosomes topically or microneedle the surface, how on earth are they supposed to heal a deep tissue tear?
They can't. That's the mechanical problem. You cannot remodel a fibrotic band deep within the pelvic floor by rubbing a serum on the surface.
The exosomes just stay trapped at the top layer.
Exactly. Because of this injection ban, patients with deep episiotomy scars are actively receiving PRP. Because PRP is autologous. It's your own blood clinicians are legally allowed to take a needle and drive it deep into the muscular scar.
So what does this all mean? To answer the core question of this deep dive, do intimate exosomes heal vaginal tears and episiotomy scars? Biologically, they have the incredible cellular machinery to do so.
But practically and legally today, you cannot inject them into a deep tear. For deep scar repair, PRP is the proven legal hero currently transforming lives.
While exosomes remain this fascinating, highly regulated surface-level treatment, fantastic for mucosal hydration but legally restricted from deep scar injection.
That's the current reality.
But I want to leave you with a final thought to mull over. As nanotechnology and synthetic biology advance, imagine a future where we can synthesize these exact exosome instruction manuals perfectly in a lab.
Building them molecule by molecule, completely bypassing human donor cells.
Exactly. If we bypass human tissues entirely, we bypass the legal and ethical hurdles. Could a simple, universally approved, purely synthetic topical gel one day completely erase the physical trauma of childbirth without ever needing a needle or a donor?
It would completely rewrite how we approach obstetric recovery.
It really would. Thank you for joining us on this personalized deep dive. We hope this gave you a clearer view of the actual mechanics of regenerative medicine. Keep questioning the cutting edge of medicine, and we'll see you next time.